Okay, welcome everyone to today's Hot Topic webinar, The Role of Doulas in Primary Prevention. Our speaker today is Georg'ann Cattelona. My name is Victoria Ellis, and I am a current intern here with the Indiana Perinatal Network. And I'm just going to give Georg'ann a quick introduction before we hand it over to her. Georg'ann has worked with families as a childbirth educator and birth doula since 1994, and she focuses on women with past life trauma or whom have experienced traumatic births. She has worked with a variety of doula programs, including Health Connect One's community-based doula model, serving as a trainer, a member of the HRSA-funded Leadership Institute on community-based doulas, a member of the expert panel on community-based doulas, and additionally as a member of the accreditation committee for the Health Connect One. She's also presented this workshop at the Indiana Midwives Association meeting in 2012 and in 2013 in Louisville, Kentucky for the Kentucky Association of Sexual Assault Programs. Georg'ann was the founder and director of Bloomington Area Birth Services as well, and in 2011 was named Woman of the Year by the City of Bloomington's Commission on the Status of Women. So now we will turn it over to Georg'ann.
Okay, great. Thank you very much, Victoria, for that introduction. Let me get my slideshow started here. All right, is it showing? People have arrived. Show my screen. There we go. Excellent. Very good. Come on, slideshow. There we are. Okay. Does everyone can see that okay? Let me know if not, if there's a problem. Okay. My goal today is to deepen your understanding of doulas and the role that they can play as part of the healthcare team. Specifically, I'm proposing that doulas can work in ways that prevent poor outcomes in maternal and child health and promote good outcomes. I know that we will have time for questions. I've built in some slides that will allow for that, and also please send those via chat and one of the staff will go ahead and ask those questions as we go along. So today's itinerary, we're going to start from the place of doulas, from the land of doulas, and then we're going to go from there to talking about cesareans and cesarean birth, and then we're going to journey over to the world of hormones and brain and behavior. And then we're going to come back to doulas again. And the one thing that I think is really helpful when talking about this kind of a topic is that to not let yourself get distracted by thinking about individuals too much, but to try to keep your statistical hat on. Those of us who work with mothers and babies, it's emotional work, it's work that pulls us in. Many of us are mothers ourselves, many of us are parents, we've given birth, we have family members who have, and it's often easy to get pulled into thinking about things from that place. And really what we'll be talking about is a much bigger picture. So individual circumstances are always just that, and individuals may have very specific things that require different responses than when we're talking about the larger picture. So I would just ask that everyone keep that in mind. Well, just to make sure that we're all on the same page about doulas, here as we start in the land of doulas, here's the definition of a doula according to DONA International, the largest doula organization. And I've put it on the slide so you can read along with me here. The word doula comes from the ancient Greek, meaning a woman who serves, and is now used to refer to a trained and experienced professional who provides continuous physical, emotional, and informational support to the mother before, during, and just after birth, or who provides emotional and practical support during the postpartum period. She, and for convenience I'm going to use the pronoun she when speaking of doulas as the majority are women, does not provide clinical care of any kind. She does not diagnose nor speak for her client. A doula is a paraprofessional, meaning that she always works in conjunction with a professional such as a doctor or a midwife, and she is part of the perinatal team. So what does physical, emotional, and informational support look like? A doula listens to her client's wishes and helps her and her partner achieve those wishes. She provides in-person support from early labor through the birth, usually until the baby is settled and is nursed. And if there are particular questions or needs, then she helps them get those questions answered and those needs met. During labor, she will work to help the laboring woman manage her labor experience in accordance with her wishes. And here you can see some doulas being trained at a workshop and learning about physically supporting someone and how to talk and touch and approach a woman in labor. If the client does not want an epidural, then that is what they work to achieve. They're not always successful at that, but that's what they aim for. And if she wants an epidural, then that is what they do. All of this is within the context of how the labor is unfolding. And all clinical decisions are made by the doctor or midwife in conjunction with the client. The doula can facilitate communication, but she doesn't advocate for her client. In terms of impact at the birth, doulas have been well researched, and here we can see a photo of a doula in working with a client. According to a Cochrane review, which we'll be referring to again later, the meta-analysis, the best results with doulas are when the doula is neither a hospital employee nor a family member or friend. Let's give you a moment to think about that. And when epidural analgesia is not routinely available, of course, these studies were very broad and went to places that where there wasn't always epidurals available, so that was a good comparison point. We do have some research that specifically looks at the role of friends and family, and researchers have found that emotional satisfaction was still there, but the improved obstetrical outcomes weren't. Nurses can also provide comfort and information, and they certainly do, but they are not at the bedside continuously. And by the very nature of their jobs, they're unable to provide just labor support, though many of them wish that they could. The continuous component, that continuous support component, appears to be essential to the success of what we call the doula dose. There were no conclusions about when labor support should start in the Cochrane meta-analysis, so it's quite possible that a doula could be working for a hospital program where she meets a client in labor and then spends continuous support there with the client until her time is up, and then another doula comes in. So we don't have research about that in particular, but what we do have is that continuous support, not losing that connection, is extremely important. So what have doulas been shown to help? Women who have doulas are more likely to have a spontaneous vaginal birth, so fewer forceps and vacuum extraction. They're less likely to request analgesia, regional or systemic. They're more likely to report satisfaction with their experience, and we will come back to that topic. And they're more likely to have shorter labors. They're less likely to have a baby with a low 5-minute APGAR score. So when you look here and you can see the slide showing you this is what the partner does and this is what the doula does, you can see that there's an overlap in these things, and that an overlap, but they're definitely not the same, and that it has the power of what the doula does is to create these much better maternal-child health outcomes. And if we go back and look at the original Klaus and Kennel study from 1991, there are also outcomes that, while not necessarily clinically significant, they are suggestive of other equally important effects. For example, in their article that was published in JAMA, Marshall Klaus and John Kennel reported that mothers who had a birth doula spoke more positively about their partners, smiled at their babies more, and thought their babies were smarter than the women who did not have doulas present. The doulas in these studies are providing continuous emotional labor support. The focus is on the intrapartum support. And I'd like to add that most doulas provide a specific set of prenatal and postpartum visits, usually as home visits, in addition to attendance at the birth. Postpartum doulas have equally positive effects on women in the postpartum period. Women who have access to social support are not isolated and are more successful at adapting to life as a new mother than those who do not have a support system in place. a postpartum doula can be key to setting up that kind of support network and can play a supportive role herself. She is part of the support. The signs of more successful adaptation rather than less successful adaptation are greater success with breastfeeding, less likely to develop a postpartum mood or anxiety disorder, and greater self-confidence. And we know that one of the most protective things against an abusive relationship is really having a good supportive network. And postpartum doulas as well as birth doulas can help with that. Now I've got this slide up of a community-based doula who was part of the team in Spartanburg, South Carolina with an organization called Birth Matters. And we see her providing support to a client. Community-based doulas are of a model that's quite different from the private practice, volunteer, or hospital-based doulas. Basically, a community-based doula expands a community health worker role to include that of the doula, so attendance at the birth and doing postpartum follow-up more intensively. She is usually of and respected by the community she serves. She's employed by an agency that provides a salary demonstrating the value of that work, and she provides a more extensive home visiting component, both prenatally and postpartum, than the other kinds of doulas do, and often they'll follow the mother-baby dyad for a year or more. The more intensive model has been shown to have a positive impact on breastfeeding, and that's something that's missing in the research about other kinds of doulas. We don't have a clear indication that doulas are helpful with breastfeeding, though anecdotally that appears to be true, but really we don't have hard numbers yet. But for community-based doulas, we do, and especially among populations that historically have had low breastfeeding rates. What is especially exciting for this data is that it demonstrates a positive impact on both duration and exclusivity. So I've got a graph for you here from Health Connect One's publication that they did in conjunction with HRSA, Human Resources Services Administration, which is part of Health and Human Services. And this is a report that is pulling together all the research from the HRSA-funded sites, which was part of a special grant through Health and Human Services. So we're comparing the PRAMS data, which is Pregnancy Risk Assessment Monitoring System, which is a surveillance project done by the CDC, and accounts for about 78% of births in the US. And so we have that as the brown line, or reddish brown line, comparing that to what we have this here, comparing have from Health Connect One's data from those HRSA-funded sites. And what you can see is that the community-based doulas for Black or African mothers in the US got much better duration for breastfeeding. They also had much better rates for exclusivity as well, which was really exciting to see. And I'm going to pause here for just a moment and see if you have any questions or comments or anything that you would like to ask about in general about doulas themselves. Okay. Please feel free to pass those questions along as we go and put them into your chat box as part of the. Here we go. All right, let's move on to the next. All right. There's widespread agreement in the U.S. that the cesarean section rate is too high. We see this coming from the American Congress of Obstetricians and Gynecologists, from the American Public Health Association, from the Centers for Disease Control, from the World Health Organization, and recently it has made its way into the media. These are headlines from 2015 and one from 2014. If we look at the long-range trend, which I can offer you here, and this is from Eugene de Klerk's Birth by the Numbers project, and you can see U.S. cesarean rates. Probably many of you have seen this kind of slide before. You can see where cesareans were in 1989. You can see the dip here, and then the steep rise, and then the leveling out. If we had what is the most recent data for 2015, we would see that cesareans had dropped down to here, 32%. So there's a very tiny drop that may be starting, though I've heard it argued that it's just going to be a plateau. It's going to kind of stay there. There's several reasons for the slide, this rise. Including changes in medical practice, more often opting for a cesarean over, say, instrument delivery, and increases in induction rates. And there have been changes in culture. Surgery has, in general, become safer, and I think we're all aware of that, and cesareans seem less threatening to everyone. And then there's less support for vaginal birth after cesarean. So this is looking at total cesarean rates. But that doesn't, is that necessarily a problem to have cesareans go up? So we need to take a look at that. What are the risks of cesareans? And the short answer, of course, is that cesareans are more costly and do carry more risks than vaginal birth. The short-term risks have to do with increased morbidity, just as with any surgery, you've got a risk of infection. And there's also issues of injury to internal organs, very unusual, pretty rare, but it does happen. Complications from anesthesia, again, not common, but it happens. And developing deep venous clots or developing adhesions. In addition, women who have had cesareans are at greater risk of developing endometriosis later. And in the year following the birth, they are at greater risk for appendicitis, stroke, or gallstones. The long-range impact of cesarean birth on the mother is also significant. First and most immediate is the increased risk of problems with future pregnancies, for example, infertility, ectopic pregnancies, placenta previa, and placenta accreta, in all of its variations for placenta accreta. And in fact, accreta has gone up significantly, and it's almost certainly directly related to the rise in cesarean rates. Babies are also at increased risk from cesarean birth. The potential for accidental lacerations during the cesarean, I don't know of anyone to whom that's happened, but again, with my big statistical hat on, I can think about okay, statistically it does occur. Immediate respiratory problems and late preterm complications, sometimes due to miscalculations of the due date. So simply having a baby delivered prematurely, it carries a whole host of problems, and those range from jaundice to breastfeeding problems. And recently, we have begun to learn more about potential long-range impact of cesareans on the child's health. And this is where some very interesting research is starting to come out. Much of these long-range effects for the child, effects that last into adulthood, may be related to the impact of a surgical birth on the microbiome. I don't know if you're familiar with that term, but we're really talking about, I think probably the best way to put it is the ecology of the flora and fauna that live on and around our bodies and in our bodies. That's the microbiome. And it appears that the microbiome is even more important than we had thought in terms of our chronic health conditions. So when a baby is born vaginally, and babies are sterile when they're born, the birth canal colonizes the baby's entire body, including the gut, changing that sterile baby into one that has the appropriate flora and fauna. Babies don't get that when they're born by cesarean, and some of you may have heard of the process of actually inoculating babies with vaginal secretions in order to try to restore that flora and fauna to what it should be. Sorting out the role of the microbiome in jump-starting the immune system might help us figure out why children born by cesarean are at greater risk for obesity, asthma, juvenile rheumatoid arthritis, leukemia, immune deficiencies, inflammatory bowel disease, and systemic connective tissue diseases. All of these complications cost more, and many require readmission to the hospital. And when calculating cost, we need to include the long-range cost for the conditions that last into adulthood. So I'm doula who's constantly doing research, trying to help parents make decisions and think about things and have the larger context in my own head. And also because of my interest in public health, I was kind of excited to see this come up. So the American College of Obstetricians and Gynecologists, actually called Congress, and the Society for Maternal Fetal Medicine in March of 2014, and this was reaffirmed in 2016, they published as part of their obstetric care consensus series a piece on safe prevention of the primary cesarean delivery. It's a pretty interesting document, and they listed clinical practice measures such as revisiting the definition of labor, dystocia, and improving and standardizing fetal heart rate interpretation and management. The majority of the statement is, of course, dedicated to clinical things, as it should be, but they do have something called alternative management strategies, and under that they listed continuous labor and delivery support, and this is what they said. Published data indicate that one of the most effective tools to improve labor and delivery outcomes is the continuous presence of support personnel, such as a doula. A Cochrane meta-analysis of 12 trials and more than 15,000 women, that same one that I had mentioned earlier, demonstrated that the presence of continuous one-on-one support during labor and delivery was associated with improved patient satisfaction and a statistically significant reduction in the rate of cesarean delivery. Given that there are no associated measurable harms, this resource is probably underutilized. Let's give you a moment to think about that. So I really needed to think about that when I heard it. I thought that is really interesting. So doulas in the birth room are potentially going to be really welcomed. And that's exciting. And to have us recognized as part of that team is really important. But it occurred to me that that really to help facilitate that, we need more dialogue about what and how. What do doulas do, and how is it that we have this effect? What is actually the mechanism of the doula dose? Now, I do want to take just a moment and say that in no way do I wish to suggest that a surgical birth is not an important tool for an OB to have in their toolbox. My background before I got into birth work is in history, actually, and did a lot of work in women's history and read quite a bit about reproductive health over time, both in America and in Europe, and I'm quite aware of the differences in maternal and child health today as opposed to times in the past. Sometimes people ask me, well, you know, you're a historian, is there some time in the past you would have liked to have lived rather than now? And it's like, no. Just take a good look at dental care and medical care, and I think I like living now. And I am grateful for the tools that we have, the shiny instruments and the antibiotics and all the things that are available to keep us healthy. But what has come clear is that it is a tool that's being overused. A low-cost and effective way to combat this overuse is to encourage the use of doulas. So what about that? What are the physiological mechanisms at play? But let me just pause briefly, very briefly here to see if there are any questions that have come up.
Hi, Georg'ann. It's Marquette.
Hi.
And I do have one question from James. He would like to know, how early on during the pregnancy are doulas involved with their client?
Well, that's a great question. So it varies enormously. So, as a private practice doula, I can be contacted as early as the first trimester. Sometimes you get that call really late. I'm due in 2 weeks. I've decided I want a doula. So if you're in private practice, the range is quite wide. For community-based doulas, they tend to try to enroll women during the pregnancy, preferably before the second trimester. It really depends also on their referral source and what agency they're working with. Optimally, I think people tend to start really as soon as the birth gets real to them. If they're opting for a private practice doula, that's when they really start thinking about it. And if birth doulas are underutilized, postpartum doulas are even more underutilized. And they often, I think, don't get contacted until the baby is born. In larger metropolitan areas where there are more postpartum doulas, I think it becomes more a part of the custom to contact people prenatally, if only to secure the services of someone and make sure they're available when you need them. I hope that answered the question.
All right, I don't see any other questions at this time.
Okay, fair enough. All right. Okay. Oh, Here's some lovely doula trainees, and it was a delight to work with them. They were from a workshop of mine. To say that a doula's impact is due to social and emotional support is not sufficient to explain what is happening. We've learned so much about brain chemistry and its influence on behavior and emotions. This means that we can have a much richer understanding of how the presence of a doula can have the kind of effect that we listed above. And I've chosen for focus today 2 key hormones, oxytocin and prolactin. And here's oxytocin. It's a hormone that's critical to the healthy unfolding of labor, birth, and breastfeeding. It plays an essential role in maternal bonding and may be important in protecting against mood disorders in the postpartum period. I'm going to draw a lot on the report, Hormonal Physiology of Childbearing, Evidence and Implications for Women, Babies, and Maternity Care. That was written by Sarah Buckley. And she lists 16 things that oxytocin does. And some people definitely call it the love hormone, but that barely begins to cover it. So women, when they become pregnant, experience a slow rise in their oxytocin levels. And in labor, oxytocin is released in pulses from the pituitary gland, binding with oxytocin receptors in the uterus. And these pulses are important and part of what makes oxytocin from the brain superior to that from an IV. We talk about endogenous versus exogenous oxytocin. The pulses appear to keep the receptors from saturation. We hear talk of an exhausted uterus, which is a way of saying in plain language that the oxytocin receptors have stopped working, they're not responsive. The pulsing quality of oxytocin released from the pituitary is thought to help prevent this, thus reducing the risk of postpartum hemorrhage. And oxytocin peaks after the birth. In fact, women have the highest release of oxytocin in their lives after they have a baby. It's higher than after an orgasm. It's higher than after a really good Thanksgiving dinner. Which are both other times that oxytocin rises. It's definitely at its highest after birth. So one of the things that is critical for understanding how doulas and oxytocin work together is to understand that privacy and security help keep oxytocin functioning, and that stress tends to interfere with it. Now, if we think about newborns, babies and oxytocin, babies have oxytocin. They make it themselves, but they also have it, get it from the mom as well. A newborn baby has elevated oxytocin levels, most likely contributing to feelings of calm, connection, and pleasure, just as adults do. Skin-to-skin contact with mother, breastfeeding, and maternal speech, all that cooing that mothers do, that helps with newborn oxytocin release. Researchers also think that oxytocin is involved in shaping a baby's brain for social interaction. We know from many other studies that brain development continues at a rapid pace in the first year, and what happens immediately after birth is an important part of this. Hence, maximizing oxytocin for a baby is not just a nice thing to do, it's potentially life-changing. Oxytocin's impact on breastfeeding, now that the mother and baby, oops, let me not go to that slide quite yet. Now that the mother and baby are calm and connected from their respective oxytocin highs, the stage is set for primal movements that initiate breastfeeding, that thing that we call the breast crawl. Interference with oxytocin, especially any separation of mother and baby, interferes with this dance. Not interfering is protective against weight loss because we've got the proper initiation of breastfeeding, and it sets up the physiologic relationship of oxytocin and prolactin. So we really need this whole hormonal symphony to be playing well together, and if we silence one section of the orchestra, we're going to affect the other. We know that oxytocin probably does play a role in mood disorders, and that disturbing that physiologic role of oxytocin is probably going to create that as well. There's been some interesting research with using oxytocin nasal spray on women who have postpartum depression, so that's something you might want to look at. And I think this is absolutely fascinating, the fact that oxytocin has an impact on nutrition and digestion. So here's a quote from Marshall Klaus, who's one of those doula researchers I mentioned earlier. When the infant suckles from the breast, there is an outpouring of 19 different gastrointestinal hormones, including insulin, cholecytokinin, I think is how you say that, and castrin. 5 of these hormones stimulate the growth of intestinal villi in the mother and the infant. As a result, with each feeding, there is an increased intestinal surface area for nutrient absorption. The hormonal release is stimulated by the touch of the mother's nipple by her infant's lips. This increases oxytocin in both the mother's brain and the infant's brain, which stimulates the vagus nerve, and that then causes the increase in the output of gastrointestinal hormones. So again, it's this whole orchestra that's going on that's really important. So let's see. There is some promising research directions that demonstrate that breastfeeding is protective against child abuse. I don't have a slide to go with this, sorry. As well as healing of trauma for the mother, and this is coming from Kathy Kendall Tackett. Again, this is linked to the role of oxytocin in promoting empathy and bonding between parent and child. And it's not just present in women, it also is there for men as well, and for parents and for grandparents. So what interrupts oxytocin? Inductions. Inductions have the potential to interrupt. So when you're pumping in that stream of oxytocin, synthetic oxytocin, what we call Pitocin, through an IV, you're interfering with her own oxytocin release and will affect the mother's oxytocin release. You're potentially going to shut off oxytocin receptors, and you're going to create a situation where she's less likely to have that extreme high afterwards. Epidurals, and in fact I have a slide I'll show you in a minute about that. Cesareans. So we know that there's this process from pregnancy, this hormonal cascade that begins in pregnancy, and if you think about an induction as an interrupt in that physiologic process from late pregnancy, really even possibly earlier than that, you're going to interrupt that flow, and it's going to potentially affect the baby and the baby's hormonal processes as well. Routine Pitocin for 3rd stage, there's some suggestion that that could possibly block that immediate surge of oxytocin right after birth. That's so important for starting that cascade with breastfeeding. And separation of mother and baby. That one is, it's really hard to wrap your mind around how even a very brief separation of mother and baby can potentially interrupt that oxytocin. Okay, here we go. Okay, here we go. Maternal levels of oxytocin with and without epidurals. So here we see no epidural. This is the normal flow of oxytocin. This is just before epidural administration, or for the control group that was in the study, 4.5 centimeters. This is 60 minutes afterwards, and then here is after the birth of the placenta. So this has been plotted on here, and then this is with an epidural, and you can see that the oxytocin release for the mother, her maternal levels, her blood levels are sort of suppressed and in fact go down and then do not rise up again as high. So let's talk about the other hormone, prolactin. Isn't that pretty? I kind of like prolactin for its curly-cued, ribboned structure. Prolactin is an important hormone that's been well studied in animals, but not as much in humans. We hear the name and immediately associate it with breastfeeding. But it also plays critical roles in 2nd stage and postpartum maternal adaptations. Prolactin has more than 300 recognized effects on the brain and the body, so it is about way more than just lactation and adaptation. It's also about homeostasis. I'll check on my time here. All right, good. So prolactin's made in the anterior part of the pituitary gland, and here are a few of its roles as it relates to maternal and child health. It supports conception and early pregnancy. It's involved in the regulation of appetite, fluids, and weight, and it's part of the regulation of the immune system, and it helps significantly with maternal adaptations. During pregnancy, it helps set up lactation by triggering the development of prolactin receptors in the breast, and in utero, the fetus also secretes prolactin and ingests it through amniotic fluid. After birth, Prolactin helps with maximizing growth and development. And it is the mothering hormone, but it's also the fathering hormone, as it is present in fathers with children under the age of 1, higher than in fathers of older children, experienced father, higher than in inexperienced fathers, and in fathers who are responsive to their babies as opposed to less responsive fathers. Other characteristics of prolactin that are important for our purposes: oxytocin, especially the pulsatile oxytocin of labor, promotes prolactin release in the brain. Prolactin is also subject to the rhythm of night and day, being higher at night. This always makes me think about artificial lights and what impact they might have. And unlike oxytocin, prolactin goes down during labor and then surges at the end of labor with a postpartum plateau at the higher level. It remains high into the first 24 hours postpartum. Sarah Buckley, who wrote that piece on the hormones of physiologic labor, when she looks at the progression of prolactin over the course of labor and birth and how it interacts with oxytocin, she finds a regulating impact of prolactin on labor. So it has a role then, even before moms begin nursing. It's part of creating that familiar pattern of progressive contractions that become longer, stronger, and closer together. In a physiologic labor, most often there's a marked early labor with far apart manageable contractions. That's the effect of prolactin. It's kind of moderating on oxytocin. Prolactin's presence in pregnancy is part of setting up breastfeeding, as I've said, and then there is that surge afterwards, stimulating the receptors in breast tissue. So babies get prolactin, not just from being in utero, but from breast milk as well. This has not been fully researched in humans, but what we do know is that the role of prolactin that babies take in during breastfeeding may be critical for infant brain and body development, suggests Sarah Buckley. When we look at the animal studies, there you see low prolactin is linked with higher mortality, poorer growth, and poorer endocrine system development. And that may help explain differences observed in formula-fed babies due to lower prolactin levels. We don't know yet, but that's something that we'd be looking at. Prolactin is critical to becoming a mother beyond the impact on lactation. So there's this thing called social desirability. Social desirability means that we want others to think well of us. The function of this for a new mother is that she understands from her community that her new role means that we expect her to take care of her baby, to put her baby first. Prolactin, that hormone, affects that behavior positively. It increases social desirability. Prolactin also appears to lower a new mother's monotony avoidance, so that she's more willing to tolerate day-to-day repetition, if not hour to hour and minute to minute, of so much of infant care, especially in the beginning. Okay, what interrupts? Oh, there's a mom taking care of her baby. And you can see in mothers that willingness to just sit with their babies for what seems like hours on end, and that is definitely the effect of prolactin. And when prolactin levels are where they should be, parents are attuned, they're attentive, and they're engaged. And I love the fact that it affects fathers and probably affects other family members as well, which I think is just a terrific thing. All right. Oh, yes. Another study found 20% lower levels of protein in new mothers' colostrum day 2 following pre-labor cesarean section. So this is where we're getting at what interrupts prolactin. Breast milk proteins have a critical role in the defense against infections and facilitate optimal development of important physiologic functions in newborns. So hormonal alterations are likely an explanation for what's going on when we see the impact on babies, that interaction between prostaglandins and Pitocin on isolated, that's the title of the article, sorry. What I want to talk about is what interrupts prolactin. So let me go here, and then we'll go back to that slide. Okay. Induction. To start with, prostaglandins may play a significant role in reducing the release of prolactin, especially prostaglandins that are administered orally. The route appears to be through increasing central dopamine, which is why prostaglandins are are an effective way to inhibit lactation in the postpartum period. Prostaglandins that are administered vaginally have not been studied in relation to the potential effect on the vulnerable fetus or newborn hormonal system. And we just saw that prolactin plays an important role in newborn system regulation. Induction, by definition, is going to interfere with physiologic unfolding of labor. Its very nature is to bypass whatever was going to happen on its own and force a beginning to labor. That's why induction should only be done when benefits outweigh the risk, done for medical indications, not be done electively before 39 weeks, if not 40. An induction puts the mother and baby both in a situation where these critical prolactin processes may not happen. For example, mother may miss out on the late pregnancy prolactin elevations that prepare her for lactation and motherhood. The baby may miss out on late pregnancy prolactin elevations that prepare him or her for life outside the womb, as prolactin helps with organ maturation and helps with the transitions that occur in breathing. And if we back up to here and think about the 20% lower levels of protein in new mother's colostrum day 2 following pre-labor cesarean section compared with vaginal birth. So you have a baby that is put at a disadvantage from having been born by cesarean with no labor to jumpstart things, plus you have that the breast milk proteins are potentially going to be missing that the baby needs for the development of a defense against infections and facilitating optimal physiologic functions for the newborn. And prolactin is a piece of that. Right. To say just one more thing about Pitocin, the use of synthetic oxytocin for induction, augmentation, or third stage management. We don't know enough about it yet, but there is quite a bit to suggest that we should be looking at how it affects prolactin. It does change prolactin release to be given Pitocin during labor. And it looks as if that single shot of Pitocin to prevent hemorrhage may have an impact on prolactin levels. So that we need more research on. I wish that I could tell you definitively, but I can't. Epidurals also interfere with prolactin levels, and cesareans do. This is an area where, again, we have more questions than answers. There's much that is suggestive, but because prolactin plays such a complex role in physiology, we need more research. So what I can tell you is that planning a cesarean before labor begins almost certainly affects late-term rise in prolactin, in labor decline, and the surge after the birth, since all of these are related to each other. The surgery itself and attendant stressors probably disrupt prolactin as well, though this is a bit harder to untangle. We know that general anesthesia and tissue damage make prolactin rise, but most cesareans are done with regional anesthesia, and not all studies to date clarify which anesthesia has been used, so we need to look into this more thoroughly. Separation of mother and baby after cesareans or even after vaginal births may affect prolactin levels negatively, since we know that skin-to-skin contact and early breastfeeding positively affect prolactin, but we do not have enough research on this topic either. There's also a possibility that the very composition of the breast milk is affected by mode of delivery, and that we can trace back to the prolactin system, which is that slide that I showed you before. All right. Let's take a break. That was a lot of hard information, and are there any questions? I may not be able to answer them, but I'm game to take them.
Hi, it's Marquette. I don't see any questions right now.
Okay, great. We will keep going, plowing on ahead then. Thank you. All right. So what do doulas have to do with this? And my answer is everything. Oxytocin and prolactin are enhanced by a sense of privacy, safety, and security by allowing as much as we can to the mom to process and have a physiologic birth. And when we cannot have an undisturbed birth, then being aware of the physiology can help us to respond with physiologic management. She's having an induction, then let's try to support her moving around. Does she need to be confined to bed? She needs continuous fetal monitoring. Can we support her in moving around? Is she having an epidural? Then can we help support her with movement from side to side in the bed, which most nurses know to do for certain. And when that's done, we do it because we know that that helps support physiologic birth. This is when we preserve as much of the pieces as possible, and paying attention to other things like the Bishop's score and exercising patience. All of that's really important. When a woman feels safest, she labors the best. And a birth doula can help enhance these factors for a laboring woman and her partner. And can I say that touch is a really, really important part of that. Doulas offer appropriate touch, culturally attuned to the client, and supports the partner or other family support person in providing appropriate touch as well. Touch lowers stress and supports oxytocin release and will support prolactin as well. I've heard, I believe it was Marshall Klaus say, every time you touch a woman in labor, she releases oxytocin. That's a good thing. The environment, being sensitive to whether or not dim lights are what she wanted. Did she want closed doors or closed curtains, and so on and so forth. And just simply attending to the presence, the doula's presence in the room. She provides this anchor for a sense of safety and security. She's the person who has an exclusive emotional and physical support role. Her calm presence and separation from the clinical team increases the mother's sense of safety. The trust between the doula and her client allows the doula to enhance the sense of privacy in the room. The majority of the people coming into the room, the nurses, the assisting staff, such as techs or students, have no prior relationship with the patient or the client. The one person that the woman may have a relationship with is the doctor or the midwife, and they have a clinical role and often are not able to be there for as much as perhaps they might like. It's challenging, especially for doctors, but even for some midwives, to really labor support and labor sit in the way that's needed. And nevertheless, they would still be filling a clinical role, which is quite separate from that emotional support role. So when doulas are learning about comfort and position changes and facilitating physiologic birth, what they're really learning about is supporting the hormonal cascade, about supporting the physiology of the laboring woman. And there's something that's called attunement. This is me with a client's little girl who was about 10 months old at the time. And our eye-to-eye contact in this moment, our focus on each other, is part of what attunement is about. Attunement is about being in sync with each other and being able to really be present with whatever it is that's going on and responsive to whatever is going on. I'm going to go back up just a moment. So doulas also have a role of facilitating social and community connections. This has not been part of the studies, but I do think it's really important to mention here, especially in light of how prolactin works. So ACOG and the Society for Maternal Fetal Medicine recommended doulas as a way to reduce cesarean rate. I'm suggesting that doulas should be recommended because their presence and actions provide protection for the physiological process for mother and baby, and probably for the whole family. That they are a cost-effective and underutilized member of the perinatal care team. The benefits so far go far beyond surface numbers, and that the enhancement of a birth experience is equal to trauma prevention, increasing self-efficacy, and healthy bonding and attachment. It lays, in fact, the groundwork for long-term health for the mother and the baby. These are founders of DONA International, 3 of them, and I offer you John Kennel's quote about, if a doula were a drug, it would be unethical to not use it. Thank you very much for your time. And I'll leave you with this lovely picture. And let me know if you have any questions.
Hey, Georg'ann, we do have another question, and
Sure.
It says, what are the similarities and differences between an at-risk client having a doula versus having a visiting home nurse? Are there any studies of both working together?
Yes, so there are places actually where they complement each other really well. I think the key question is whether or not a home visiting nurse is going to be a companion during the birth and labor process. If you're speaking of a program such as Nurse Family Partnership, then in that program they provide wonderful at-home services and home visiting services, but they don't go to the births. And so there are sites around the country where Nurse Family Partnership works with community-based doula programs, and together they cover then that full spectrum and allow for that intrapartum support, which I think is really critical and key. So based on what I have observed and what the studies point to, is that there are things that you get from having that continuous emotional support during labor that if that's not there, you miss out on. And it seems to be really important.
Okay, thank you. Are there any more questions? Okay, well, if you do think of any more questions, feel free to contact Georg'ann with the information that's on your screen right now. You're also welcome to contact Indiana Perinatal Network. You can actually, there's a tab on our website, or you can email ipn@indianaperinatal.org. And, Georg'ann, we do have some more questions.
Oh, excellent.
It looks like we have time. So, all right. How can we as doulas provide sound bites of this info to relay the doula's importance? That's it. That's the question. That's great, actually.
Well, I think that is a good question. And I think one of the questions is, who's the audience? So I think for clients, this isn't, I mean, unless they're just ready to, geek out on the wonders of physiologic birth, which some of them are, then that would be really exciting and fun for them. To take a look, for example, at Sarah Buckley's stuff, or to get on Childbirth Connection and look at some of the information there. I think for colleagues and providers and other professionals, I think picking something that is really salient for that particular person that really matters to them in their practice, and saying, you know what, this is how I can help you do this. You're working in a community where this is really important to you. You're working with moms. You see this come up. This is how I can help you. And then pulling out that particular thread. I think people are more interested in, what's going to help them do their job better, and which I think is completely legitimate and fair. Does that help?
Okay. All right, and then we have another question. How can we effectively include childbirth education in the doula care practice? And she adds, I'm thinking of more at-risk clients.
Yeah. So the childbirth educator role and the doula role are actually separate. And there's been some good writing on why they should be separate and kind of what that means. I think that, though, at the same time, having said that, doulas are always educating and making referrals to resources. I think you have to meet people where they are, though, and really begin with saying, tell me what's important to you and what is it you need to know. And sometimes just simply asking the question, you're about to have a baby, tell me what you think you need to know in order to get ready. And then starting from that place. So trying not to say, I know what you need, but rather saying, tell me about it. You're going to have this baby in June, so what do you need to have this baby? And they'll interpret it how they need to.
Great. Okay. Oh, all right. I do have another question.
Okay.
It says, oh, yes. Okay. She's asking if we'll be providing the slides. And yes, all of you will have access to this webinar. It will be on our YouTube channel, which you will be able to get to through our website. It usually takes about a day or so to convert the recording of the webinar in order to put it on YouTube. But you will be able to go back and visit it again because there was a lot of information. So that's why we do that. Okay, anyone else? We're getting a few thank yous, Georg'ann, so that's
Oh, wonderful. Well, thank you.
yeah. Okay,
Great.
I think
Thank you for your help, Marquette.
all right. So I'm going to now turn this over to Lauren, and she has a few words for you.
Hi everyone, I'm Lauren Moore. I'm also an intern at IPN. I just want to thank everyone for listening and I hope you enjoyed it. I really liked it. And I want to remind you of some events that are coming up. So we have our next webinar, with the breastfeeding series, which will be held on Tuesday, July 19th from 2 to 3 p.m. And that will be with Tina Babbitt. And then the next webinar for the Hot Topic series will be on Tuesday, August 30th from 1 to 2 p.m. and Abby Hunt will be doing that one. And you can register for both of these on the IPN website. And then our annual breastfeeding conference is coming up. It will be on Friday, August 26th at 8 a.m. And this year it's going to be at IU Methodist Hospital. And it will feature keynote speaker Kimberly Seals, who is a best-selling author. And you can also register for that on the IPN website. And registration will be open until August 26th. And then I also want to remind everyone to please fill out the short survey once the webinar closes. It would really help us out a lot. And thank you for listening. I hope to see you at the next webinar.